Hey, everybody. Welcome back to Therapist Uncensored. This is Sue Marriott, and I'm sitting with Benjamin Fry. And so welcome to the show, Benji.
Thank you so much. Pleasure to be here.
Is it okay for me to call you Benji?
Yeah, sure. Call me Benji. I grew up being called Benji, so I will definitely respond to the name Benji.
Well, I jumped to that because in some of our interactions, I've heard people very affectionately call you that. Okay, why don't you
Nice.
begin
Yeah,
by...
normally when I was in trouble, I'd be called Benjamin. So,
Yeah.
maybe I could figure out how it's going by which word you use.
That's true. Yeah, when I was in trouble, I was Suzette. So same thing.
Right.
It was a scary sound. So why don't we just start by you describing yourself for our listeners?
Well, that is a broad remit.
Yes, it is. It's a bit of a Rorschach.
Well, I guess I work in mental health care, and I own a clinic, which is a residential clinic for treating trauma, which we set up in 2011. So I've been doing this for a while. And I think from that, other things have flowed, and I'm doing other things as a result. But before that, I was a trained psychotherapist, very much in the kind of European tradition of, I guess, rooted in psychodynamic psychotherapy. And I did a bit of media work. I worked a bit for the BBC. I presented or co-presented a program with them on spending addictions, which is quite a light-hearted program. And I did some magazine work and things like that. So the turning point for me really, though, was my own personal breakdown in 2009-10, and coming to America for treatment with modalities I'd never heard of, such as EMDR and somatic experiencing. And not only was this a kind of personal life raft for me, but it professionally opened my eyes to a whole world that I didn't know. And I think traveling as I did from England then to get a treatment in America, it's sometimes very eye-opening when you move country, move culture. It's kind of like time shifting in a way, because the future is usually here. It's just not very well distributed, as one famous writer once said. And so when I guess when I found something that I felt was a real step change in the landscape of psychotherapy, not only was it personally very welcome, I literally think it saved my life, but it also just totally reinvigorated my interest in the field and made me think of all the things that were possible, particularly in places where this work hadn't really penetrated yet, like the UK. The irony is now we have people coming from all over the world to our clinic, including from America. So I guess things kind of come full circle. But back in the day, it felt like there was a tiny rear guard of people who were using the word trauma in a way that was connecting it with treatment rather than just descriptions or etiology of problems. And that, for me, it just blew my mind. It was spellbinding.
Mm-hmm. So shall we, if you're okay with it, if we can start a little bit more with your personal story and kind of how you got to where you are today?
Well, do you want me to begin at the beginning? I was the child of an American mother and an English father. And sadly, my mother was diagnosed with aplastic anemia when I was 4 months old, and then died when I was 11 months old. So that wasn't a great start. I was then, I then went to live with one of her best friends who had an adopted daughter, similar age to me. My father apparently would visit on weekends. And I was there for a year or two. Nobody seems to quite agree on that, but something like that. And then my father remarried, and I went back to live with him and his new wife, who became my stepmother. But actually, I must have been 3 at the time. She basically became my mother in the sense that nobody ever talked about my mother. So it was kind of a family taboo in a way that there'd been a previous wife and mother. So I had this tremendously bad start, I guess, by conventional assessment of what would be a good attachment journey from 0 to 3. By the time I was 3, I'd had 3 mothers. I lost the first 2, and the third one wasn't a particularly great relationship. So I was obviously going to be pretty messed up on some fundamental level. But then, life continued, and I was very lucky with everything else in my life, very fortunate. My father became a successful businessman, and I went to amazing schools in the UK. I went to Oxford University, and I had, every opportunity anyone could wish for in life. So I think these 2 factors were quite a dangerous combination, because there was a kind of explicit message, I guess, from me, but from the world of, not only could I do anything, but that I should be able to do many things, and that if I didn't, I was a failure. I mean, it's a great privilege to have an amazing education, but it does set the bar quite high for what you do after. And I sometimes think that it's like, sometimes that bar is so high that you either achieve what you're expected to achieve or fail, and there really isn't any room for success beyond that. Anyway, so, I had all that going for me, but then the things that I think, as we all know, as people get older beyond like school age, college age, many other factors determine the quality of your life and the outcomes of your life. And many of them are kind of relational health factors, mental health. And I think all of those factors for me started to become harder and harder to manage. So I probably just struggled more than I thought I would. I started having panic attacks in my 20s. I eventually got engaged the end of my 20s, found that very overwhelming, had children, found that very overwhelming. And I think really started to become kind of non-functional. I was functional enough that I could kind of pretend I was functional. I was trying to run various businesses and spinning plates, and I suppose, conjuring an illusion of some sort of independent, successful businessman. But I think really I was more drowning than waving. And in the end, it all kind of caught up with me. And I think when I was 38, 39, I really just fell apart. There was a financial crisis in 2008, which impacted me. We discovered that my then wife, was pregnant with our 5th child, unexpectedly. It was a lot, and I was kind of cratered by it in a way that seemed disproportionate to the problem. I mean,
so some of that early history begins to show up.
Well, so this is what I began to think about. I was a trained psychotherapist, so I thought, what's the story really about? But my symptoms were pretty bad. First of all, I was just very worried a lot, and then things just got worse. I became, I guess, clinically anxious. Then I started having problems sleeping, and all of these things just got worse and worse. And I think the lack of sleep, plus the kind of 24/7 motor of sympathetic activation, probably started to change my brain chemistry in a way that I really felt like I was beginning to lose my mind. There were times when I was just totally overwhelmed by emotion or, catastrophic thinking or suffering. Just not sleeping is awful. And then, of course, I couldn't work anymore. It's just a sort of train wreck into the abyss.
And are chemicals involved at this point? Substances?
No, I've never used chemicals for anything other than occasional recreational amusement. I don't really get on very well with drugs. Part of my problem is that as I got worse and worse and worse, I kind of came out of the psychotherapy world and for the first time ever entered the psychiatry world of asking for that level of help. And I get on very badly with substances. So, at the height of my anxiety, I was asked to take all kinds of drugs, which then my body would react to as if it was some sort of alien substance, and I would increase my anxiety. So it was really very difficult.
So this is so you have the foundation where that's shaky. This is important because when we, as therapists, think about where someone is, on a developmental scale, it's the way I think of it is more of like Swiss cheese, so that we all have these pockets of pain, but we can do pretty well a lot of the times, especially in good circumstances, when we're fueled by, like you're saying, this privilege. But at some point, some of your pockets, the pockets of trauma, sounds like began to push through. And what happened?
It was more like a volcano erupting than pushing through.
Mm-hmm, mm-hmm, mm-hmm.
I didn't know this at the time. I didn't really know anything about trauma. I couldn't have conceived of it in these terms. I just had very, very florid symptoms. And in conventional psychiatry, they had nothing to say. I literally went to the top psychiatrist in the top hospital in London, and he sat there in his big office, and he said, well, you've got generalized anxiety disorder. And I said, yeah, I've just spent an hour telling you that, but what's wrong with me? And he literally said, it's in a book, I can show it to you. It's a thing. It's a real thing. I was like, well, this really isn't very helpful. So my first brush with psychiatry actually left me more scared than before I'd come in, because I'd always thought if things got really bad, you could always go to the doctor or go to a hospital and there'd be some help. But it seemed to me in the psychiatric hospital I was in, which is a famous South London hospital, there was very little that anyone was adding to the story at all, at great expense.
That they could name it, but not tell you where it's coming from or what's causing it or what. Yeah.
And what I saw
thus couldn't help you. Yeah.
I didn't see anything going on in the other patients that gave me much encouragement either. So I think that's when I really got scared. When I thought, actually, it's all emperor's new clothes, and nobody really knows what they're doing. And that was...
It's terrifying.
I felt like I was alone with a problem I couldn't understand. And the people you expected to understand it were just pretending to understand it.
Mm-hmm.
And that was hard.
Mm-hmm. And what punched through?
What do you mean?
Well, there's a transformation. Is that what you were talking about earlier about moving to the getting treatment in America?
Oh, yeah. So what happened is that I left that hospital, was trying to take the drugs, didn't go well with the drugs, recovered a bit, and got worse again. And so I'd been in this cycle for over a year, I guess. And I was just in a terrible state. I barely slept. And I just became more and more suicidal. So I wasn't suicidal in the sense that I hated my life, I wanted out. I was just exhausted of pain. Just exhausted of just getting through the day, a minute at a time or a few seconds at a time. And it was interesting. I just, I had this idea that I could have a rest, just get a break. And so I would think about that, and I would provide some comfort. Fortunately, as a trained psychotherapist, I knew about the theory of the ladder of suicidal ideation, that it kind of starts off as a sort of vague notion, then becomes more concrete. And then, if you're unlucky, it moves on to things like making plans and then assembling equipment, and then you haven't got much left to do. And I think that the reason it escalates is because each escalation, a bit like taking, drugs, like taking cocaine or alcohol, eventually you need more and more and more to get the same effect. So I found myself one morning, far down this ladder of suicidal ideation. And I have 5 young children. I was in a state of probably terminal despair for myself. I don't really know. Wasn't quite tested. I'm not sure if I would have done everything that was as hard as it was to do to save my own life for myself. I might have done, but I'm not sure. But for
you're not sure that what?
I'm not sure that I would have tried to not die just for myself. But I felt like I couldn't, I couldn't leave my kids without trying everything. And someone had suggested that I had trauma and I should go to some clinic in Arizona to treat trauma and et cetera, et cetera. And I didn't know. I had no idea. I mean, I found it hard to get out of the bedroom, let alone out of the house. So the idea of getting on a plane and going to Arizona from England was overwhelming. But I just thought, I have to try. I mean, I can't check out without doing it all. So that's what I did. And unfortunately, by then I'd run out of money. So I had no income, a bit of money in the bank. And what the treatment center wanted me to pay was a few $1,000s less than what we had in the bank. It was the winter in England, I had 5 kids at home with my then wife, with no money. I mean, it was terrible. But I went nonetheless. I didn't tell her that I was suicidal because I actually thought I probably wouldn't come back. And I thought that would be too much to leave her with. So off I went one Saturday with my family kind of baffled why I was getting on a plane to Arizona. And then I was in this kind of big rehab hospital type place, which helped me in the sense that I wasn't alone. And when I was having breakdowns, there was kind of nurses around. I was incredibly unfunctional. I mean, I remember barely speaking for days on end, shuffling around in a hoodie, just walking from one place to another because it was so hard just to sit still. I would sit at the communal tables with people and just listen to them talk and not speak. But one psychiatric nurse really helped me. She helped very slowly get me onto a very low dose of SSRI. And actually listen to how hard it was for me to do this because I was so anxious. And that really helped. And I think after about 4 weeks of that, I started to feel like I could begin to sleep again, just from the medication. And in that 4th week, I could have left then and gone back to England, never done a moment's trauma treatment. But I happened to bump into my roommate who was in the patient lounge talking with somebody. And as usual, I had nothing to do, so I sat down with Bob and Colleen. And she was explaining somatic experiencing to him. She ran the aftercare unit, which was called Melody House, where Pia Melody and Peter Levine had pioneered a kind of collaboration for actually doing something about trauma rather than just talking about it. They did that, I think, with Francine Shapiro as well, which is why they had EMDR. Anyway, I'm talking to Colleen, and I was saying how, she's asking me about my symptoms. I was saying how it just, people are always talking about the worry and the anxiety, but I was always feeling like, it was bigger than that. It's like my body is trembling. And she said, yeah, I know, I can feel it. It's in your stomach, right? And I was like, yeah, it's in my stomach. I mean, for a year, no one would even listen to that, let alone have any idea what I was talking about. And I was like, well, how do you know? She said, well, because I can resonate with it, because that's what we do. We're somatic therapists. So this was 2 minutes in, and I was like, okay, for the first time, I met someone who knows what's wrong with me. Like all these fancy doctors, hospitals, therapists, faith healers, God knows what. Everyone had opinion, uncles, aunts, friends, godfathers. When I look back, everybody had an opinion and everybody was wrong, which is quite scary when you're very vulnerable, particularly when you run out of money and you need people's help. You're so vulnerable to people just saying, well, this is what you should have and I'll do this for you. And, they're all wrong. Literally, none of them had a clue. But they're all very convinced they were right, or might be right. And so I signed up to go to the aftercare program. I managed to beg 4 weeks of treatment. And then we started. And, we started with EMDR and somatic experiencing, individual sessions and group work as a community where we learned what it was like to be in a relationship with other people, despite the fact we had trauma and attachment wounds, which was a real eye-opener. I never realized that you could feel connected to someone even when you disagreed with them. Or even if you didn't like them, and you wanted to bring up something conflictual. It's extraordinary. Anyway, it was amazing what they did there. It's just life-saving. And so many people were having astonishing recoveries. It was extraordinary. So, but then, again, I'd run out of money, and I think my father didn't want to pay for me to be there, and nobody seemed to know that I was suicidal. Eventually, that kind of part of the story came out, and it was like, my ex-wife said, "Is that true?" And I was like, "Well, yes, but I feel I'm getting better now." And then they let me stay there a bit longer. But I came out of there after 3 months. I barely see my kids for 5 months. I mean, I've barely seen them for a year and a half, really. I mean, it was a terrible time. It was a terrible experience. It was terrible to be ill. It was terrible in the clinic. It was terrible. It's terribly hard recovery. I mean, doing EMDR on early life trauma was only possible, I think, because I was in a residential setting where I felt very safe.
And where you had enough holding.
Yeah, and the clinicians I really trusted, and the community I really trusted. And, you could come out of EMDR and go lie on the sofa and sit there shaking. And someone would walk past and they'd look down and go, "Oh yeah, a bit of EMDR. Yeah, you'll be all right in a couple of hours, don't worry." There's an extraordinary opportunity, really. Anyway, I came out of there kind of, on the mend, but still pretty fragile. But my life was a shit show. I mean, my kids didn't hardly remember who I was. Obviously, my marriage was taking a hammering. I was completely broke, unemployable, unemployed. But I remember when I left my last session, Colleen said, "Well, what do you want to do when you go back?" And I was like, "Well, I don't know. I can't think of anything to do other than set up a clinic like this because it's so amazing." And somehow that's what I ended up doing.
That is remarkable. That is remarkable. And I heard you describe some of the early times of your clinic, and operating out of houses that you weren't, without money, all of those things. What was the turning point, do you think, in starting the clinic that made it go from just an idea to, okay, now I'm on the right path?
Well, the catalyst was I wrote an article for the Times newspaper in London about my breakdown and recovery and these interesting new things that I discovered in America. And I had one throwaway line in it, which said something like, "Be a dream of mine to set up a clinic like this in the UK." And a woman contacted me and said, "Look, it's funny because I've rented a big house to do a clinic, like a rehab, but I don't really know how to do it. Do you want to come and do your clinic here?" The other person who got in touch with me, believe it or not, was Peter Levine, who got in touch with me out of the blue and said, "I read your article in the Times. I'm in London in a couple of weeks. Do you want to come and hang out?" And I think these two things combined gave me just enough of an impetus to think, well, maybe this is possible. Now, it's funny how things turned out, because we got everything ready for this clinic in that house. And I think 3 days before we opened, the landlord illegally repossessed the house using a gentleman who used to be in, I think, the New Zealand Special Forces. It turns out that the landlord was a little unscrupulous, and there wasn't anything we could do about it other than go to court. But physically, there was nothing we could do about it. Peter Levine's interest in the project also waned. And somehow I ended up in this position where I had nowhere to do the clinic. I had 4 clients who were expecting to start, and we'd had one full-time member of staff who, in the chaos, said, "I can't do this, it's too chaotic." And so actually we started the clinic in a holiday let, renting a house week by week. And I was the only full-time member of staff. So we had part-time staff, and we had a driver for free from a work program from the government, an old car and an even older laptop, and that was it. And we began, and touch wood, is still going.
And part of your inspiration was bringing these bottom up therapies, these new therapies. So far you've mentioned somatic experiencing and EMDR.
Those were
Were those kind of the anchors? Yep.
Yeah, those were the two that we did in that clinic. And remember, this was in early 2010. Now, since then, the whole world has emerged into almost a kind of colloquial embracing of the word trauma and its ideas. Back then, it was hard to really have a conversation with clinicians. Like in the UK, if I went to see doctors, say, let me tell you about this great clinic, you couldn't even begin a conversation about trauma because it was a language they didn't even understand. So, you had to educate people to talk to them. It was impossible. Now you can't stop people talking about trauma, and even when it's probably not merited or relevant. So it's been a big change. And along the way, of course, we've learned so much about trauma treatment and healing and so many other modalities. So at the clinic now, we use IFS, Janina Fisher's model of TIST, sensory-motor psychotherapy, trauma-informed yoga, equine therapy, all sorts of things. Obviously, mindfulness, meditation, yoga. Brain spotting is another one we've used. I'm trying to think. I'm probably leaving a few out. But, as you know, there's been an explosion of interest and competence, I think, in developing efficacious techniques. So, and we've ridden that wave. I mean, I've always gone to as many conferences as I can go to, met as many people as I can. That's how we met. Because I was looking for, what else? We'd have clients and some of them would do well, and then we'd have some clients they wouldn't do that well. And, I think in the kind of landscape of policy in the UK, I remember doing quite a lot of work with a think tank in policy. And the idea there in kind of Department of Health circles was if you help 50% of the clients who come through in an ordinary outpatient setting, that's considered to be success. Mm-hmm. And I always felt like, well, what about the other 50%? Mm-hmm. It felt a little irresponsible. But then I just thought about an individual, because I was an individual. And it didn't help me that someone said to me, CBT and SSRIs will probably help you. They didn't help me. And then what are you going to do? They had no answers. So my obsession was always with the people that we were helping less than the people we were helping more. And to this day, I remain relentlessly curious about what can we do to improve things, what can be better. I mean, not just me or we, but all of us. Mm-hmm. What are we missing? And sometimes I think that mental health treatment if you think of it as a science or a branch of medicine, it's like being in physical medicine in like 1730. Mm-hmm,
that's right.
I mean, you could go down Harley Street in 1730 with a sore tummy and knock on a door and go into a big room with a man in a suit and a tie, and he'd tell you some extraordinary theory that sounded plausible, and it was in a book, and he learned it in medical school, and it had a name, and then he'd put leeches on you or something, and charge you £400, and off you go. And people back then probably thought that was a good idea. I'm glad I did that. And some of them would have got better, and some of them not. And sometimes I think that we're in just the very, very early stages of real knowledge, real science, real understanding, and therefore, obviously, treatment that works. Because I don't think humans can really solve problems until they understand what creates the problems. It's kind of the way we think. Mm-hmm. This, for me, was the revolution of coming across trauma theory, is that I finally had someone explaining to me what was wrong with me. Like, the reason why I was shaking at the age of 39 was because at the age of 5 months, I'd been sat in a room with my mother who'd just been told she was dying, and I didn't know how to handle it. Mm-hmm. And so when I lost my money, or when I had a reversal, or when I had a problem in my marriage, that's where I was. I was an infant, drowning in adults' disassociated horror, pain, agony, and terror. Mm-hmm. And no, I wasn't going to cope with that.
Mm-hmm. Well, you have a unique view in putting together your program and being relentlessly curious. What are your thoughts kind of today about the different modalities, these bottom-up modalities, or these that you're beginning to mention, like a couple of things. One is, are there any particular ones that stand out that you are like, if you're going to do one thing, this is it? And then also, do you have a theory of mind about what's happening across the board about why these bottom up things are working?
Sure. I didn't mention polyvagal informed treatment, which is an umbrella that goes across everything we do. I think if you're going to work with the nervous system, which is how I don't think about working with trauma really, I think about working with the nervous system. Step number one is safety. So for me, the polyvagal theory is a science of feeling safe. And therefore, it's a very useful thing to engage with, particularly as it's framed for clinicians by Deb Dana. We can kind of infuse any modality with polyvagal theories, and also a residential setting. So that's, for me, really important, particularly when you've got a lot of people together in the same place a lot of the time. And then you want to know, well, what works? What would you kind of go with first? That's an impossible question to answer, so I'm sure you know. I look at it like this. So you've got, let's say it's like a crystal. And the problem is in the middle, the unprocessed material maybe, or the attachment drama, all the developmental issue is in there somewhere. And the crystal has many faces. If you try to go through one face, maybe it doesn't let you in. But if you try and go through another face, maybe it does. So what we try and do is try and go through as many of them as possible at the same time, without overloading people, just to see what works. So obviously, the answer to your question of what should you do? You should do what works. How do you know what works? I don't know. The only technique that I would consider is a kind of cross-the-board umbrella is, as I said, the polyvagal theory. I started personally as a patient with somatic experiencing in EMDR. And I think if you have an EMDR practitioner who's also a somatic experiencing or somatic therapy trained clinician, that's a really good place to start because they won't overload your nervous system with EMDR. Doing EMDR without that training, I think, worries some people who work with the nervous system. So it's tricky. I mean, EMDR is a very active intervention. Somatic experiencing can be very gentle, very passive. So the combination is quite good. Again, I mean, that's just a perfect example of trying to push through two parts of the puzzle and seeing if, one can unlock the other. You talk about the theory of mind as well, and that is relevant. So for me, I don't use the word trauma much, but what I think about is unfinished responses to earlier threats. So for me, trauma is all about threat and safety originally. And it's a subjective sense of threat. So, two people in a room having the same experience, one might feel overwhelmed by the threat, the other might just feel a little disturbed by it, but be able to meet that level of threat. And I don't think you get to trauma unless you get to overwhelm, because I think what we think of as trauma is unfinished business. So something happened to me. If I'd had all of my capacities and all of my resilience, I might have responded fully in the moment, but I didn't. So I was partially frozen, so I have something left over. That leftover business is just there forever until it isn't. And I think it's that leftover responses to things that then changes who we are, changes how we respond to the next experience. And that necessarily changes how we respond to relationships, which when we're young changes how we respond to our caregivers, which changes our developmental pathway. So much change from our authentic self can come about as a result of just an unfinished response to a threat. So there is a theory of working with trauma that a lot of the gold, if you like, is to complete those responses to threat. I mean, the heart of techniques like somatic experiencing or sensory motor psychotherapy or EMDR is this idea of processing, where something is completed, something's taken through to the end. And I think I would include that as the kind of bullseye of the process of everything being held in other ways. But then there's also this developmental piece about attachment and relationships, which I've become more and more interested in recently. Actually, I now work separately to all of this, just privately, occasionally as a couples therapist. because what trauma does to development and attachment and relationships and how that shows up in adult relationships has become very interesting to me. So, but these things are related. Like, the less reactive I am, the more space I will have in a relationship to choose my behavior, if I can put it like this. And the more space there is in a relationship for two people to be different without being overwhelmed, I think the more chance their relationship has of working.
Mm-hmm. I love what you're saying, because it's more inclusive, because we can go in and do a piece of work in somatic therapy and move these pockets of trauma, release them. And that's good. That's net good. And also we might still be a jerk in the world, or we might still, you know what I mean? We're still going to have our personality. We're still going to have, like you're saying, the developmental shaping of how we're interacting in the world. So it sounds like what you're describing is kind of doing the full circle, so that you're looking at the developmental piece and the trauma pieces together. Because again, you can sit in psychotherapy for a very long time just doing the developmental and not get to the trauma. And you can also get to the trauma and not necessarily do the developmental.
Mm-hmm.
Would you agree with that characteristic?
Well, I don't, I'd be careful for myself for making sweeping statements like that, because so many of these journeys are so unique, and so many clinicians are so different. And the same clinician can have a very different journey and experience with a different client. I do think that you are identifying two areas of work, though, which are related, but not the same.
Right.
And it's probably one of the frontiers of what we're all trying to do at the moment, is to figure out that relationship. I don't think it's particularly perfectly articulated. I mean, there are techniques like sensory-motor psychotherapy is very rich in understanding things like character strategies, which influence relationships and are related to trauma. And, many trauma modalities have that in them. What I reflect on of my time in treatment is that twice a day we'd meet as a community, as a group, and we would learn to do housekeeping, if you like, as any community might, but in a way that didn't scare each other. Bear in mind, we're all in there because we're kind of in a florid state of trauma reaction to something. And it was a very careful, very formulated way of allowing people to be together that was moderated by the therapist leading the group. And it gave us a new experience. It gave us the experience of being able to be connected and in our truth, which most people had never had. I mean, this idea of being sort of securely attached without having to surrender who you were, or, manipulate, or pretend, shut down something you're upset about. It was entirely novel in many ways. I mean, most people who suffer from a lot of trauma deal with relationships by, either shutting down or acting out, or, fawning or manipulating, whatever. It's never just, here is me, who are you? And that's just too much. So I always credit that journey as having two paths. And the two paths were intricately linked somehow, but I don't really know how. The best I think I can say is what I said before, that I do think that the lower my reactivity is, the less alarming it is to be in a relationship. And the less alarming it is to be in a relationship, the more that I might find trust and security with others. And that then itself could feed into being able to be more comfortable with my own reactivity. So there's definitely a symbiotic relationship between trauma and attachment. And there's definitely a relationship between, if you like, cleaning up your inner world and cleaning up your outer world. How we build a specific model about how they link, I think many people have tried and are trying and will continue to do so, because it's probably highly individual and highly complex.
Well, I like you keeping moving. It's easy to, like you said, lump or say something that's too sweeping. And each time you're talking, you're moving into nuance, and you're moving into the individual, and you're reminding us all of the both the order of all of this, of the world, and also the chaos of it and the individualistic nature of it. And I really appreciate that. And I think there's not enough of that, because there's camps, there's big personalities, and there's camps, and there's even polyvagal theory. You can say, oh, I'm a polyvagal therapist, but what does that mean? And which might bring us to I think the newest technology, at least that I've heard about, which is this PhysioCam.
Oh, yes.
Can you
well, you talk about polyvagal theory. Yes. Look, I mean, first of all, let me just say, there is an inherent tension between the fact that brilliant people have been pioneers in this field. And you don't be a pioneer without championing your cause. And if we want new knowledge, we have to accept that people are going to champion it because they're the pioneers of it. There are very few generalists, very few people who integrate across that spectrum. It's one of the pleasures I've had, because I run a clinic where, as I said, we just do what works. So we better figure out everything or we're not doing our job. But I do understand that there's a kind of tribalism, and often the joke is that people who have the smallest differences between what they do hate each other much more than people that are totally different. I mean, you can find a trauma therapist and somebody who thinks you can heal trauma by kayaking, and they probably get on better than a somatic experiencing therapist and a sensory motor psychotherapy therapist. So that's just the way it is. But that's okay.
That's part of the human condition.
Part of the human condition. And I do think that the next generation of kind of leaders in our field will be people who aren't pioneering but are interpreting and assimilating and guiding and doing all the kind of things that you need to do to maybe reverse that dynamic. I'm hugely grateful.
Or reintegrate it, to get it reintegrated.
Yes, sort of integratist point of view. Can I do a little bit of name dropping? Would that be?
Yeah, no, please do.
Well, I recently did a workshop in Costa Rica that was led by Esther Perel and Paul Brody. I played a very small part in this, and I did a morning on trauma and relationships. And Esther said one of the reasons why she was happy for me to do that was precisely that reason, was that I did not come with, a cause that I championed. I was happy to look at it all and see what I could learn, because I did this for myself as an individual. And what can I learn from all of these different modalities or schools or ways of looking at it? And then I was curious about how that feeds into relationships. So I think that, I think there's an appetite out there for moving forward with the implementation of many different individual silos of knowledge. And that's probably going to be part of the next generation of development of this field, I think. I could be wrong, but it feels like it to me.
No, I actually totally agree. And I think that that's been some of the success of this podcast, is that it is very broad, and so some of the work that Ann and I have done is very much this integrative, how to actually apply the science. Because a lot of times you can get trained and then want to go, then you feel like you're smart and you feel like you know something, and then you bring it in to help. But, it's not, again, and I think this integration word that Dan Siegel talks about is just a really nice frame for it. Yeah. So what about this physiotherapy cam, and how does that fit in? And I'm just so fascinated by it.
Well, it's not a physiotherapy. It's called the PhysioCam.
PhysioCam.
It was named as such in academia by Dr. Stephen Porges, who, with colleagues, invented this. Now, the story is that I used to be the clinical director in the clinic. I used to do all the morning groups and some afternoon groups. So I would do a lot of group work. I really enjoyed doing the group work. And, in a group, what we're really trying to do is get everybody to drop into the parasympathetic. I mean, we're not trying consciously, but the great groups,
safety.
Great groups ended with everybody just kind of connecting in social engagement system or parasympathetic, whatever you want to call it. And I often had this fantasy of having a kind of nervous systemometer that you could almost wear on someone's sleeve, so that not only could they see, but everyone else could see. And it's kind of like I have a slightly nerdy brain. I mean, I did physics and philosophy at university. So I look at problems and think, well, what else could you do to solve it?
That I have to tell you, that idea is terrifying. For some of us, it might just live in these activated states.
Okay, but
to broadcast that.
And anyway, these were kind of my general musings and fancies.
Yeah.
I met Stephen Porges in London. I went to one of his workshops and we had dinner after. And I said to him, could you invent me like a wearable nervous system monitor? Because this is a time when, wearables were the talk of the town, Fitbits, things like that. And he said, well, the thing is, I've already done it, but I did it with a camera. I did it for the American government and they stuck it on a shelf. So it's just sitting there doing nothing. It's called the PhysioCam. I said, what do you mean you did it with a camera? He said, yeah, I can point a camera at you and give you a readout of your nervous system. So I was like, well, that sounds fascinating. Maybe we could make that work in clinical practice. I don't know. And so we started this journey, which was totally new for me. I went off to Chapel Hill in North Carolina, I think, and went to see Maria, who invented it with him and Greg Lewis, and just saw this thing in a lab, which was a clunky piece of kit made out of bits and pieces of God knows what. I had no idea if it worked or anything. But it seemed kind of cool. So we started a collaboration to see if we could develop this into something that clinicians could use. I've been on a long and windy road with it, I think, as you do with any invention. And initially, we were going to have like a box. Well, first of all, we turned it into a laptop computer and we started using it in the clinic and trialing it. And what we realized was that it was incredibly accurate. So what we did is we made the screen go red, yellow, or green, depending on the direction of travel of someone's activation. Now, we're working with some incredibly experienced, skillful somatic therapists. By this time, I wasn't the clinical director anymore. We had some good people doing it. And so they would look at the screen and look at the client, and they'd be like, yeah, that's exactly what's happening. So we sort of validated it using our human technology, which was very encouraging. And I'd always felt that whenever I'd used it. It seemed intuitive. It's like one of those things that just like, it goes this color and that color, and it just matches your feeling.
And what do you have the colors associated with? You said red, yellow, and green.
Well, they could be anything. They could be any colors. They could be up, down, left, right. But we use Stephen Porges' traffic light system from the polyvagal theory, I think. Also, it's an intuitive thing to understand traffic lights, right? But probably not, maybe not in the long run the best colors to use, because people do associate things with colors. Eventually people will just be able to choose their own colors, so it's fine. But what we wanted to do was turn it from this clunky computer that you almost needed a tech in the room to use on a computer screen into a nice little shiny box that you had on your desk and a shiny ball that would glow different colors. And we were very excited about that. And then the pandemic hit, and everything in therapy changed from being in the room to being online. And what we realized was that actually, we'd try to take a computer and turn it into something that went in a clinical room. Meanwhile, the clinical room had gone into a computer. So it seemed like a bit of a waste of time. So we went back to the idea of what would it be like if right now you and me were doing therapy and we were using the PhysioCam. What would that be like? Because the other thing that people report a lot during the shift to doing online work is that it works, but a lot of therapists find it harder. I don't know if you relate to that.
100%.
Right,
100%.
And tell me about that. Why is it harder? What feels harder?
Well, I mean, I think this is going to, you're missing information. You're basically missing information.
And that information is the information your body would pick up unconsciously, automatically by being in the room with me. Right? And so you have to work much harder to get the same level of information. You have to concentrate on it. People report being exhausted after a day of Zoom sessions. But what the PhysioCam can now do is if you imagine seeing me on the screen here, and you have like a bar up one side, which just goes from red at the top through amber down to green at the bottom, that puts my body back in the room with you. And you just don't have to work so hard, and you can see it. But the other unexpected consequence of this, which, when you're a trauma therapist, I think eventually you take for granted the ability to track your own nervous system. Lots of people don't have that. They don't even know what it means. And we've started to see, because we've used this with a few test pilots, and we've spent a couple of years trialing it with people to try and figure out what works and what doesn't, is that people will start to notice what's going on the inside because something on the outside is telling them that something has changed.
Yeah, it's like that biofeedback.
Yeah, we can't say what's changed or why, or even if it's good or bad. I mean, sometimes being activated is good. You're excited. You just got the news, you got into Harvard. You're not, it's a good reason to have activation in your system. But when I really thought, wow, this is a good idea, was when the guy that was working with me on the programming side, who was the first person ever to use it, he just had it on his screen open for 2 months as he was just, working on this programming. He said at the beginning, he would notice it changing and he'd be like, oh yeah, I just got a text about the lease on this place and, I was upset or I was happy or whatever. And he said over time, he would start to just check in more and more as he saw it changing. He would always find something. And then he found himself walking down the street and he could do it without the PhysioCam. Mm-hmm. So he went from being somebody who had never been interested. I mean, he's a great guy, but he doesn't need therapy. He's not in therapy. He's got no use for it. And he went from having no kind of introception of his state change to being quite well aware of it simply by watching an external device give him that feedback. So it's something that people can use on their own. They can use, like we're talking now. You could be my therapist and show me your nervous system. I could be your client and show you my nervous system, or both, or neither, or whatever we want.
Well, what is it actually measuring?
Well, that's Dr. Porges' secret sauce. He would say, well, I shouldn't speak for him. I don't know exactly what he would say because the things he says are so clever I can never quite repeat them. But it is measuring the activation in your parasympathetic and sympathetic nervous system. That's what it's a proxy for. But what it's actually physically doing is it's creating a heart wave of your heartbeat from looking at the tiny microscopic changes of color in pixels in your face. Because every time your heart beats, your face goes a slightly redder and then less red. And so he puts together this heart wave. And then he has this algorithm that he's developed, which he can reverse engineer the tiny perturbations in a heartbeat to the inputs of the different branches of the nervous system. And, that's his special sauce. So we licensed it from him and from the university where he invented it. And I think in the second half of this year, it's going to basically be available. Therapists will be able to download it and use it with their clients, and we'll see what happens. As I said, we've been trialing it with about 20 people. It's fascinating. We have group supervision every month with Deb Dana. Mm-hmm. It never ceases to amaze me that it's one of those things that you don't really know what people use it for, or even if it's useful. And then interesting things happen. And there are clients now who say, if it's not working or they don't have it or something, they're disappointed that I don't want to do a session without it. Where is it? Mm. Which is interesting.
Mm-hmm. Well, and it's so powerful getting that visual feedback. And so I could see even just from that perspective how valuable that is. And the client's seeing it and the therapist is seeing it. I looked at it before we got online, and now it's not a clunky box. It's just something that gets downloaded on your computer. Is that right?
It's just like, you know how you select your camera as we're doing this call? If you wanted to, you could have a different camera. It's just another camera in the list of cameras you can select in your Zoom or Riverside or whatever it is. So once you've installed it and turned it on, you can select it anytime you want as a webcam, and then it will show what we're seeing now. But in addition, there's this nervous systemometer running up and down the left of it, which was my fantasy in the first place. It was like, build me a nervous systemometer. He said, well, I've already done it.
Well, that's wonderful. So you are on the cutting edge of all of these things. It's pretty incredible. I love the integrative piece of this. Do you want to say a little bit about your clinic? And you've got a book, and you've, what are the things that you're interested in right now that you want our audience to know about?
Well, look, I don't really want to sit here and advertise my clinic. I like coming to talk about these things. But when I was very desperate, very, very desperate finding the help that I needed was an impossibility. And it was a 1 in a million chance that I found it. I mean, literally, I was in the same campus as the place I needed, and no one knew that I needed it. You know, even the colleagues of the people that work there know I need it. So I am passionate about letting people know that our clinic exists. I mean, it's a very functional residential clinic where we specialize in treating trauma, and can be an alternative to hospital. We have a very high level of care. We have 5 or 6 levels of care now, from an equivalent to a hospital through a sort of community house, through a halfway house. And in London, we have a whole building near Harley Street where we have a day clinic, which is, Monday to Thursday, intensive outpatient, I think it's called in America. And we do outpatient stuff there as well. So people do move down that pathway and sometimes even up it. So there's a really comprehensive ecosystem there to treat people who are thinking that their problems are as a result of trauma, but at many different levels of care. So people can come in total crisis, and if they've got the time and the money, they can progress through that to anything they want. I'm not going to say it's perfect, and I'm not going to say it's the right thing for everyone, because I think that's inevitably not true. And if I thought it was perfect, we'd stop improving it, which would be a disaster. And there's no way anything is the right thing for everyone. But I do think almost every day that there's someone out there right now that was me in that bedroom in 2009, and they don't know we exist, and we're the perfect place for them. So, thank you for giving it some airtime, just so that your listeners can know that it's there. And I think if there's anything about it that resonates with anyone as a clinician or as a client, just go to the website and look around, download the brochure, read it.
Right.
If I always feel like when we talk to people who do assessments or consultations, I say to them, look, does any of this make any sense to you? Does it feel like what you're going through? Because that's what happened to me. It just felt right. If they say yes, then, you look at maybe taking it further. So that's what I would like to say about the clinic. We exist. Go to khironclinics.com, have a look around, and if it resonates, get in touch.
And why Khiron?
Oh, Khiron is the Greek myth of the wounded healer. So, which was obviously me. And, for many years, I used to joke that I set up the clinic in case I needed one to go back to and had a relapse. Because at least I could get to it, because it wasn't so far away and it'd be free.
I want to go. I just want to go anyway.
Well, it's a nice place. I mean, but in terms of your other questions, I wrote a book called The Invisible Lion, which is actually my attempt to integrate all these things we were talking about, these kind of silos of trauma theory, trying to understand it. And it's because I used to do all the initial consultations at the clinic. So I'd have the same conversation, like an hour and a half consultation, where I'd try and explain all this stuff over and over again. And eventually I thought, it'd be easier to just write it down. And what we do, we give it to everyone who comes to the clinic, and it helps them begin a journey of kind of common understanding, and also saves time in clinical practice. I mean, you imagine psychoeducation is incredibly important, I think, in trauma therapy, because it instills safety, and it also instills a sense of, in that moment where maybe processing is happening and it's really scary, you have a theory of mind, as you put it, about why this is a good idea. So psychoeducation, for me, is a very important platform. It takes quite a lot of time. And it's fine in the clinic, we can do lectures and what have you, but if you're working with someone an hour a week, you can save yourself 6 hours by saying, read this book. And, that's why I wrote it. That's what we do it for.
Well, I really like that, because the other thing, the mental health industry is an industry, and it is a business. And I always think about even psychedelics, and that the world of psychedelics, it becomes exclusive, and it becomes, you have to know someone, or it's, even though the molecules are very inexpensive, there's these barriers of care that happen just very, very, very quickly. So books and things like this are a great way. And this podcast, honestly, is partly to make the information flat, and it's worldwide, and it's so everybody gets this. And so anyway, I'm just supporting you about put the psychoeducation in people's hands in all kinds of formats.
Well, and if you can't afford a book, it's on Audible as well if you have credits, but even if you can't afford a book, go to my website, benjaminfry.co.uk, and just read the blog. I mean, pretty much everything you would read in the book, you'll read in the blog. So like you, I'm passionate about having the information available in every possible format. Going to a residential clinic if you don't have insurance is incredibly expensive. So, what can you do for all the people that's out of their reach but need it? Well, information is a really good starting point. I've had people get in touch and say, look, I read your book and it's changed everything for me. I mean, it's almost, psychoeducation can be a treatment for the right person at the right time in the right place. So, if anyone wants a book and can't afford one, they just email me on benjamin@khironclinics.com and I'll send you a free PDF and you can read it. And it's not, you have to pay to print books, but it's not about the money. It's about how can we get information out there so that the majority of a conversation has this stuff in the background rather than we're seen as a sort of freak splinter group. When you look at what's happening in the world today, what's happening in politics, if everybody understood the stuff in my book or polyvagal theory or any one of these pillars of trauma theory, if everybody just at least understood one, just as well as they understand things like it's important to remain breathing, to remain alive, the world would be a different place. We would solve problems differently. We would see our problems differently and our solutions would be different and everything would be easier. So, like you, I'm a big champion of just distributing accurate, useful, digestible information.
Right, which that's another problem, right? Is that there's attachment also is a term that is really misunderstood, and but yet there's influencers and folks that I think all have good intentions, but it's a confusing concept. And again, that's part, it depends on, are you talking about developmental attachment? Are you talking about adult attachment? Are you talking about, some of the neuroscience, there was an article I just actually distribute, talking about, that talked about, they had found the link. This was in a neuroscience journal. They had found, the physiologic link between mother's internal scripts and the brain of the baby, that you could take a picture and you could see it. But then they concluded that it was not related to maternal attachment. Mm-hmm. But the reason that there was that, disconnection was that they were using the adult attachment measures, which are not at all the same thing as developmental attachment.
Right.
And, so then now they're putting out attachment isn't the factor, when actually what they were measuring was developmental attachment, basically unconscious scripts. So it is a funny world as far as getting accurate, staying clear about what we mean. And there's research even that I found that even, we were talking about different formats. So even podcasts have this measurable impact on, psychoeducation podcasts have a measurable impact, especially for folks that are, don't have the vocabulary, the reflective, psychological vocabulary, that in particular, those populations that just sharing information like you're doing and like what we're doing, actually has an impact. So it's an exciting time to be doing this kind of work. So say again your clinic, spell it, and say again how to reach you.
So the clinic is Khiron Clinics, Khiron clinics.com. And you can reach me at benjamin@khironclinics.com.
Wonderful. And the name of your book?
The book is called The Invisible Lion. You can buy it anywhere in the world, from Amazon, on Audible or Kindle or paperback.
And, one thing I found is if you have a premium Spotify account, you can get a whole bunch of, like our book is free there. And right. I think that you can get a whole bunch of books for no charge, just part of your subscription.
Right.
Okay. Anything else before we end that you would like to leave our audience with or suggest or share?
No, I just want to thank you for the work you do. I mean, I've seen you around at a few conferences, and
we've shared some meals, shared some lesbian wine.
Right, the best kind of wine. What other wine is there? It's been great, and I just want to thank you for having me on. But more than that, thank you for putting in all the work you do to get this message out there. Because actually, I think in the end, there'll be a tipping point, but it'll take 1,000, if not 1,000,000 episodes like this before something that should always have been obvious seems obvious. And, on that day, I think the compass of hope for our planet will change.
I agree. I think this is the thing that we can do, is to just keep putting that hope out there. And I do, when you were talking about there's somebody out there like me, and that's the dream of what we're both doing, is like somebody gets touched and moved and begins to move into action that can become a trajectory that can really change the course of people's lives. I think that this science is that. It's life-changing and real exciting to be part of getting it out in the world. All right. Well, thank you very much. And everybody that's listening, if you found this valuable, please do share this episode. Leave us a rating and review. That helps other people find it. And in the meantime, we'll see you around the bend.